Follow-up means not as if you have done the laser and patient is okay. She has mentioned that even if you have not done the laser again, then patient will still continue to improve upon. But then also we have to look into the various parameters to follow up these patients, which is very important. Not as if the end of the game, by doing just a laser photocoagulation, you have finished the case. The follow-up should be included as per the history and examination. That means the duration of diabetes, a perfect control, that be HbA1c, fasting blood sugar. Diastolic blood pressure is also very important than the systolic blood pressure. Lipid profile. Any neuropathy or nephropathy is developing alongside this, because diabetes, if suppose patient is suffering with diabetes, diabetes can cause the nephropathy and neuropathy also, so you must look into that also. Medication, especially the insulin, oral hypoglycemic, antihypertensive, lipid lowering drugs are also important to consider. Follow-up history as examination is concerned. Hello, ये चेंज क्यों नहीं हो रहा बेटा? हाँ ठीक. The visual acuity is also important. Then measuring of IOP, slit lamp microscopy. As we are in habit of doing fundus evaluation mostly by doing the indirect ophthalmoscope, we dilate the pupil. But if you are suspecting the neovascular glaucoma or neovascular angle glaucoma, then you must do undilated pupil gonioscopy, because dilated pupil results will not be there, because overcrowding of iris will not let you know into insight of the angle of anterior chamber. So undilated pupil examination is important. One can use the small pupil or Skipin's Pomerantz. There is a very good interesting history. I must recollect that how the things evolved. The small pupil was not developed by, it's as per the nomenclature, but it was a Skipin's Pomerantz. Pomerantz was a physicist with Skipin's in retina sheets, and he was a high myopic physicist. So once Skipin's wanted to examine his fundus, so he could not bear the light. If you have got yourself examined by indirect ophthalmoscopy, it is very difficult. The bright light doesn't permit a high myop to be examined by indirect ophthalmoscope. So he went into indulged into the process of developing a indirect ophthalmoscope, wherein without dilating the pupil, you can examine this. So it was a principle which was given by the Pomerantz, who himself was a physicist working with retina sheets in Skipin's, Boston. And thus Skipin's Pomerantz indirect ophthalmoscope has come, which doesn't require any dilatation of the pupil. You can examine the fundus without dilating it. So it is important in case if you are looking for a post laser patients, especially the angle, without dilating, you can use the small pupil indirect ophthalmoscope and can examine the fundus, and then simultaneously can do the gonioscopy. As I have already mentioned, non-midriatic fundus cameras are also available. Indirect ophthalmoscopy, non-contact biconvex lens, because that gives you a stereoscopic three-dimensional view. You can very well evaluate this. And the gold standard was initially in our time was a 3-mirror Goldman mirror, by which you can examine from anterior to posterior, and magnification was much higher than compared to the 78 to 90 D. You must look, once you are examining these things, you must look for the iatrogenic hemorrhages, vitreous hemorrhages. Monitoring of intraocular pressure is very important, because many times patients after lasers can develop the higher this, and you may lose the patient by glaucoma, because of the glaucoma. And record keeping is utmost important. Utmost important, that give you an idea how the patient is faring and how many times you have done the laser or so. Previously we were just putting up the scar as far the retina is concerned. I'll just let you know. The record keeping is very important. You must record whatever the laser you have done. Not only the record the laser which you have done, but in case of ROP screening patients or ROP where you have done the laser, you must put the record, because patient will not tell you. It's all your record which will tell you how the patient is faring as far the ROP is concerned. And number of laser sittings are all important. Previously we were just mixing up a cross, just the laser is done. Now we are putting up a cross. As far the sitting point is concerned, you can put up your mnemonics or your nomenclature. You can put up alpha, beta, gamma, theta, and epsilon. So the patient will not know that where the laser is done, but you know that it is alpha, beta, theta. So that is very important, that because patient will require many sittings of the laser photocoagulation. You must know in where you did the first sitting, where you did the second sitting, where you did the last second. एक मिनट बेटा. And if facilities persist, you must do the fundus photography. Fluorescein angiography, yes, nowadays we are not doing it because the advent of OCT angio also, and being an invasive procedure, not many patients are done. But yes, initial footage or details of retina photocoagulations were based on a fluorescein angiography, ischemic and non-ischemic version. In high resource city, you can do optical OCT also to keep the records. OCT angio I have already mentioned, there's a new development is there, although many things are required to be done further on this development is concerned. Even the older versions of OCT can have a upgradation of OCT angio, which is not that superior as the coming OCT angio is coming, but you can improvise the existing OCTs by adopting a software which can develop it to near OCT angio instead of buying a newer device. That's the important message. Laser is not a one way, one shot. You require many umpteen times of evaluation of your patients, and so one sitting laser is not the end of the game. So that's very important message which I have given in a joking way, but this is correct versions, because these patients require regular follow-up at a regular interval so that you can treat them perfectly and they can restore the workable visions. Otherwise, many patients who are landed into problems because they once up, like कोई patient ने cataract कराया तो अब तो दिखना ही है जिंदगी भर. But it's not so in laser. Cataract laser is different. Laser you require a perseverance, patience, and patient has to come to a umpteen number of follow-ups in fact. Perfect control of diabetes if diabetes is the cause, perfect control of hypertension if hypertension is the cause. As far the evaluation is concerned, the laser treatment is evaluated 2 weeks after the retinal photocoagulation, a constant follow-up first in 1 to 2 weeks, then after 3 to 6 months, and preferably then annually. Additional laser photocoagulation performed in cases of new degenerative or a progressive complicated cases of retinal lesions. Things to look after the laser photocoagulations are maculopathy, because if you have done the excessive burns, the maybe macular edema may come up, formation of macular epiretinal membrane, and sometimes iatrogenic retinal detachments also because of the rhegmatogenous retinal detachment. Exudative detachments because of the higher frequency. If I am not mistaken, Kamalji has presented a paper where the Diamox helps as far as reducing this. And then I have gone into the literature. Yes, there was a paper published by the Alan C. Bird from Moorfield Eye Hospitals. He accidentally used Diamox in a case of a glaucoma who was suffering with a diabetic retinopathy. Then edema subsided. Then Alan Bird, with collaboration with Donald Gass, who was a pathologist, formulated that yes, Diamox or acetazolamide helps in reducing the blood aqueous barriers, thus reducing the edema and thus helping in the cases of diabetic retinopathy indirectly. A case of glaucoma which was given a Diamox for glaucoma improved macular edema because of acetazolamide. The dose is not the same 6 to 8 hourly, it's only twice a day 250 milligram. So in some cases where edema persists, you can give a Diamox, this is anti-glaucoma drug, to reduce the edema, and thus once the edema subsided, you can further go for a photocoagulations. I just mentioned that sometimes during the lasers, new vessels may bleed and then can lead to intraretinal hemorrhage, vitreous hemorrhage, and choroidal effusion if excess is there. Rare complications, as I have Pranav has also mentioned and Dr. Kamalji has also mentioned, because previously we were not understanding the techniques. A incorrect laser photocoagulation can cause the corneal burn, because otherwise laser beams goes directly to the retina. But if it is not improperly focused, it can cause raised IOP, pre-retinal subretinal fibrosis. Sometimes the lens photo opacification can also. They are because of the incorrect focusing, in fact, because many times patient moves his hand or head, or sometimes you are not properly aligning it. Some of the late complications are impaired color vision, macular peripheral scotoma, visual field loss, and reduced night vision. Alarming symptoms are increase in flashes, floaters, pain, redness, significant decrease in vision, sensation that field of vision is obscured, black curtain. That's very important. Serious adverse effects of laser photocoagulation are uncommon, but excessive laser photocoagulation power, inadequate, incomplete treatment, lack of retinopexy along their anterior margin, obviously excessive large retinal areas. Precautions? I'll just skip. Subretinal vitreous hemorrhage is there. Vitrectomy, if vitreous is not resolving, then you can perform the vitrectomy within a month's times. And retinal detachment is there, either do the lasers around the tear, or if required, a conventional retinal detachment surgeries. If new vascularizations are coming, an additional laser photocoagulation is required to be done. Retreatment interval should be between 3 months. Thank you.